So I'm here to speak to you about patient safety. About patient safety, not as we know it, by looking at what it is that healthcare providers do wrong, but rather by complementing that process by also looking at reporting what it is that we do well. The vast majority of the literature out there in relation to patient safety focuses on minimizing how much things clinicians, nurses, physiotherapists, pharmacists do wrong. But if you look at this normal distribution graph, which is lifted from Eric Holnagel's seminal paper called Safety 2, it's only a tiny, just over 2% of healthcare interactions that we have that end in an accident or a disaster for the patient. However, more than 95% of the literature surrounding patient safety focuses on that tiny 2%. That means the rest of the 97+% of our everyday healthcare interactions where we get adequate, good, or even excellent care, we fail to learn on, we fail to build on. Why do you think that is? Bob Weir's put it very succinctly and beautifully. Trying to understand safety by only looking at incidents is like trying to understand sharks by only looking at shark attacks. And by incidents, I mean negative incidents that have resulted in patient harm. Now, I Googled it last night, how many deaths from sharks there have been in the world last year. And number 2 came up. There were 2 deaths from sharks last year. And yet there are millions of sharks around us. And yet we tend to focus on those 2 shark attacks because it's headline grabbing, it's negative, it's dramatic. And, we're Cypriot, we have Greek blood in us, we like drama, so it's even more accentuated in the Mediterranean. So play along with me. Why do we have this negativity bias? If I ask you to tell me something about this slide and try and avert your eyes from the obvious spelling mistakes, I can guarantee you none of you would have said, this is a correct slide. Every single one of you would have spotted every single spelling mistake. Slightly more subtly, if I ask you to tell me something interesting about this slide, I will guarantee you that the vast majority of you will have picked up the obvious mistake in the middle. And yet, when it comes to something interesting about that slide, I promise you that the 4 correct answers on there, statistically and mathematically, are at least 4 times more relevant as a piece of information than the 1 obvious error. And yet, almost the entirety of patient safety initiatives focus on that 1 negative and not what it is that healthcare providers do well. And now I'll tell you a story very close to my heart. It's a personal story. So back in 98, I took my A-levels. I always wanted to be a doctor. Since the age of 5, I wanted to be Dr. Stavridis, who's a pediatrician who I used to have. And I consider myself blessed because I come from, my parents have always been there for me. They made my education and my brother's education their priority, and my health. And they're still there for me now, and they're here in the stands watching me today. And in 98, I took my A-levels. This is before Cyprus was in the EU, so I was quoted, I needed 5 A's at A-level to get into a British university to study medicine. And just to play it safe, I thought, I'd take 6 just in case I don't get one of the A's. And that's what I did. So I did that. I went to the army, and then about August time, in 40-degree heat in Stavrovouni, an envelope came with my name on it, and I opened it, and that's what was on it. And I was delighted. I was delighted because I knew I'd finally got the chance to become a doctor in the UK. So I queued up at the Gapsimi, at the canteen, to buy a phone card, and then queued outside the phone boxes to call my parents' landline because it was before mobiles. And I called them with great excitement in my voice. Mom, Dad, guess what? I got into med school. I've got 5 A's and a B. And to this day, I still remember what the first question they gave me back was, where was the B? Now, does not reflect badly on my parents. I would have probably done the same. But it's innately built in humans to focus on negativity. And we should not do that when it comes to patient safety, because it's draining for staff morale. It makes staff retention worse. Poor staffing levels makes poor patient care. Okay. This is another evidence that negativity bias surrounds us, is what makes the world go round, and it's not a good thing. This is a screenshot from yesterday BBC News about the 10 most read BBC News articles yesterday. So number 1, job losses. Number 2, critically injured. Number 3, new virus spreading. 4, virus spreading. 5, volcano eruption. 6, complaints. 7, sexual abuse. 8, Harry and Meghan don't have any privacy. 9, someone dies. 10, devastation. Every single piece of news on there is negative. Okay, negativity surrounds us, but negativity is not good when it comes to patient safety initiatives. Okay, this is how everything is described in the medical literature. There's a negativity culture, adverse events, never events, critical incidents, SIRI, which stands for serious incident requiring investigation, risk, and error. All these words have negative connotations, and it's the healthcare providers that bear the brunt of the weight of those words, because these are directed against clinicians, nurses, physios, anyone who comes into contact with patients. I work in children's intensive care, and this is one of my patients, and I'm sharing this picture with permission. And if a mistake leads to this child being harmed, he is my first victim. He's our first victim. And but I know I'm a professional. I've been training for 20 years to be where I am. And every single child that comes to my unit, I adopt personally. It's my duty of care and my nurse's duty of care to do my best for that child. If I fail them, it has a significant effect on me. My mood changes, my confidence changes, I become more abrupt, and I essentially am the second victim. And this is known as the second victim effect. But second victim effects then lead on to third victim effects. Who do you think bears the brunt of my short temper or my frustration? It's my wife, my daughters, and my colleagues around me that have to deal with me and my disappointment for the rest of the week. So evidence strongly shows that all this negative language surrounding healthcare and how we approach patient safety initiatives has a detrimental effect on staff, and by extension makes patient safety worse. When I started my new job as a consultant a few years back, the first thing I noticed at the new unit was that we had poor staff retention, especially nurses. Nurses would leave, stop nursing altogether. That led to poor staffing levels, which then led to poor patient safety. And we looked at why that was, and there was only thing in place for patient safety was a reporting system for critical incidents, so things that had gone wrong. So we decided to follow the Learning from Excellence initiative and see if we can create a platform whereby we could report when it was that things went well in order to complement all those negative things that were being reported. And if I ask you to define harm, it's quite easy to define harm. You know, we can say, oh, this child lost a limb, a leg because of something you did, or this child died, and you can pinpoint exactly and define exactly what harm is. But if I ask you to define excellence, nearly all of you will give me a different answer. It's quite a nebulous, an abstract thing to describe. So, someone described it to me as trying to catch a moonlight in your hands. It's quite difficult. Um, but we did create this platform to try and boost morale and improve patient safety. And before we introduced the platform, we introduced the standardized way of assessing staff morale before the intervention and after the intervention. Um, It's called the Short Warwick Edinburgh Mental Wellbeing Scale. It's quite straightforward. 6 questions, which you can read on there, scored from 1 to 5. And the staff did it before and 6 weeks after, and now we've done it a year later to see what impact it has had on staff morale. And we did some other measurements to see if that was translated in better patient safety and better patient care. So it was a free text that they could write on this platform. 4 questions: who did something excellent? Where did excellence happen? When? And what lesson can we learn? And this would ping into my inbox. I would read all of them, print all of them, sign all of them, and give a letter of congratulations to the person that was nominated and a person of thanks to the person that did the nominating. And that meant that the consultant body, so high up in the hierarchy of the unit, acknowledges what the healthcare staff did, whether this was a nurse, a physio, or a pharmacist, and so on, because we're all a team. Okay. And various themes started emerging. Themes about compassion and how good we are at compassion, about empathy, team about each other looking after the team morale, team about others going well and above the call of duty. And this reflected in better patient care. All this positive feeling reflected in nurses finding their voice, being more empowered to speak up about concerns they had about patients. So the prescription errors went down, our central line infection rates went down, our ventilator associated pneumonia rates went down. We had less staff sickness, less staff calling off sick, less staff stopping nursing. And it was like a ripple effect that spread across the unit, like a contagion, like a coronavirus, but in the good way. So it spread outside this unit. And I'll tell you another story where an excellence report was put for someone outside the unit. So we had a girl called Charlotte. Again, I'm sharing the story with permission. Charlotte was 16, and she had a life-limiting illness. She came in quite unwell, and we knew that she had 6 to 8 hours to live, no more than that on the unit. She was on maximum support on a heart-lung machine. Quite very poor prognosis, almost certain she wouldn't survive. Problem is, Charlotte's dad lived in the south of England, so at least 6 hours away drive. So we called the police. We say, this is the situation. I know it's not in your job description. Is there anything you can do to get this father to say goodbye to his daughter before she dies? And this policeman, out of hours, he wasn't even on shift. He put him in a police car, blue lights down the motorway, and the dad managed to see Charlotte for 1 hour before she died. And it meant the world to him. And that policeman got an excellence report, and he's framed it and put it over his desk. So this kindness has spread outside the unit and is still going strong. So this works. And this is merely after 6 weeks of us introducing this. So the orange bits are the positivity scale beforehand, and the blue scale is 6 weeks later. And we've done a year later now, and it's even higher. So as long as there's someone to look after the excellence reporting system and take ownership of it within the clinic or the unit or the hospital, then it's proven that it works for staff morale and patient safety. And I will leave you with this, something Mother Teresa has said. Kind words can be short and easy to speak, but their echoes are truly endless. Being appreciative of each other, being kind to each other, and saying thank you looks after staff morale, makes everyone feel valued, and reflects in better patient care. And it is perhaps the simplest quality improvement measure you can take. Thank you very much.